today's today's e-learning program, which is clinical cardiology for the pediatrician, and our special focus because our mainly registered candidates are the MD pediatrics, DNV pediatrics. So very basic things we have kept. We have covered history, examination, chest X-ray, CHF, shunt lesions, and now this is cyanosis. And it's I attended Sir talk on this particular topic, and it is so mesmerizing. Means it's such a basic he talks about that it's I think nobody can be better than Zulfikar sir to cover cyanosis and the congenital cyanotic heart disease. Sir doesn't need any introduction. He is very senior IIP person and doing lot of work in cardiology from the very basic point of view. He has special interest in the rheumatic and the Kawasaki disease. Very good academician, and his presentation, I can imagine our PGs will enjoy this presentation. The panelists are Dr. Vikas. Dr. Vikas is from Aligarh, private practitioner, but he is doing the main IIP office bear from the Aligarh, Dr. Vikas is. And other is Roli Srivastava. Roli is a pediatric cardiologist in Medanta, Lucknow. So I request Dr. Vikas to just start this presentation, introduce sir, and then sir can start his presentation.
Thank you very much, ma'am. Uh, it's your brainchild, and thank to all the office bearer of team AOP UP, Dr. DM Gupta sir, Dr. Bhagwani, and who have taken this initiative of online teaching in like we are doing in DIAP. And Munish madam has taken all the pains to design, collaborate, and working on all the days, including Sundays. And we are thankful to Zulfikar sir, who has spared the Sunday afternoon post lunch as per sir only. And again, as madam said, he didn't require any introduction. Learning from you and listening to you, sir, is always a delight. So, between you and the esteemed audience, I welcome you, sir, on the platform of AOP UP e-learning cardiology. Please, sir, over to you for your deliberation. Thank you, sir.
Thank you. I think a great afternoon. I think Manish has been a very close friend of mine for some time, and in between, I just want to request her again to have a new edition of her echocardiography monograph. Great. I mean, recently only in Indian Academy of Echocardiography National Conference, I made a lot of use of that book. I think it is time that we should be persuaded to have another edition, a new addition to her excellent book, was co-authored by none other than Dr. Srivastava. And speaking about Dr. Srivastava, I think this particular topic, the discussion on cyanosis and cyanotic congenital heart disease, and of course, Dr. Rowley happens to be a worthy successor, not only in name but also in profession to Dr. Srivastava. And I think one of the this particular talk, I think, has draws a lot from an article by Dr. Savitri Srivastava sometime back in the 90s when I was doing my subspecialty training in Sri Chitra. So with that, I think we will start with the cyanosis and cyanotic congenital heart disease in children. And whenever we speak about both cyanotic and acyanotic, whenever we touch upon the cyanotic congenital heart disease, people are scared, especially the postgraduates, because they will be saying, "Oh my God, this is all Greek to me." In fact, literally, it is true because the term cyanosis basically comes from a Greek word called chronosis. So there is some relationship to that also. So basically, I think we also speak about the cyanotic congenital heart disease as a hypoxemic congenital heart disease, where there is a decreased oxygen saturation of arterial blood, which we also call as cyanotic congenital heart disease. So either cyanotic heart disease or a hypoxemic congenital heart disease, you need a desaturation, that is arterial saturation should be less than 95%, 94 or less. Whereas clinical cyanosis, it occurs only when the arterial saturation is somewhere around 80 to 85%, maybe between 75 to 85%. So that is the slight distinction between calling it as a cyanotic, clinically cyanotic congenital heart disease and a hypoxemic congenital heart disease. And in a cyanotic congenital heart disease, when the arterial saturation is around 75 to 85, the PO2 in a child will be somewhere between 40 to 50 millimeter of mercury, whereas the PO2 in a newborn cyanosis will be between 30 to 42 because of the fact that they have an excess of hemoglobin, which will bind to the oxygen. Now, as a preamble, basically cyanosis. Two great people, Lunsgaard and Weinstein, said that the cyanosis is due to a reduced hemoglobin of more than 4 to 6 gram, 4 to 6 gram in a capillary blood. So this we must remember when give a tribute to these two masters, Lunsgaard and Van Slyke, who wrote a book, and especially Lunsgaard wrote a monograph called Cyanosis. So for a clinician, a bluish discoloration of the skin and mucous membrane due to increased approximately 4 or 5 gram per deciliter of a reduced hemoglobin content in the capillaries is called cyanosis. We also can have cyanosis when there is a excess of two pigments like in the blood, that is methemoglobin and sulfhemoglobin, which are totally different from congenital cyanotic heart disease. So primarily, we must be very clear about what is normal saturation, 95 or more, what is desaturation, less than 95, and the clinical cyanosis somewhere between 80 to 85%. And we must also classify cyanosis into a central cyanosis, which is the key word today, versus peripheral cyanosis. Then among the central cyanosis, we should be assessed as a uniform central cyanosis or a differential cyanosis. And also we have a very important term called acrocyanosis, which could be physiological in the newborn, maybe up to 1 day or so, but not more than 1 day. And postgraduates are sometimes asked to differentiate between a central cyanosis and a peripheral cyanosis. The answer is that cyanosis is local in peripheral, naturally. It is basically found in the cold extremities, does not touch the mucous membrane. And if you apply warmth to the area, the cyanosis disappears. And of course, the gold standard, of course, you take an arterial saturation, it will be more than 95% in a what we call as a peripheral cyanosis. Now, when we speak about the uniform cyanosis or a cyanosis, central cyanosis, we can divide them into uniform central cyanosis and differential cyanosis. And for a differential cyanosis to be clinically evident to a clinician, the saturation difference between the upper part and the lower part should be more than 10%. Whereas by definition, we can ask you what is meant by differential desaturation. It is around 5% difference between the upper limb and the lower limb. So usual situation or among the rare causes of differential cyanosis, the usual situation is upper limb is pink and the lower limb is blue. The classical one which we have studied during our MBBS days is PDA Eisenmenger. Then in the newborn, we will have a persistent pulmonary hypertension and a critical obstruction of the aorta, like an interrupted aortic arch or a critical coarctation. That basically will present as differential saturation, not probably as a evident cyanosis. Then we have a very rare situation where you have a upper limb will be more desaturated and lower limb will be relatively pink in a DTGA with a large PDA. That is very important, large PDA with pulmonary hypertension with or without a coarctation. And we must also know one or two pitfalls in this cyanotic heart disease. That is, cyanotic congenital heart disease can exist without clinical cyanosis when the saturation is between 85 to 95%. And sometimes a large left right shunt with the pneumonia or something or a heart failure can cause a mild desaturation. And before going on to cyanotic heart disease, I just want to mention grading of clubbing because at least 50% of subspecialty trainees make mistakes on the grading. It is very important for the examination. Grade 1 is increased fluctuation of fingertips. Grade 2 is obliteration of nail bed angle. 3 is increased AP diameter of the fingertips. And lastly, advanced clubbing. Grade 4 clubbing is a drumstick or a parrot beak appearance. And we must go back, especially the postgraduates, should go back and read about the three important signs in assessing clubbing: the Shamroth sign, the phalangeal depth ratio, and a Lowy bond angle, which we will not discuss now. Now we come to the clinical approach to an infant and a child with a congenital cyanotic heart disease. See, as Shakespeare said, past is prologue. So naturally, we must know a little bit of history on cyanotic congenital heart disease. Probably the earliest description of a child who died very young due to blue color was from an Egyptian papyrus 3,000 years before Christ, that is around 5,000 years. And it's very interestingly the first description of the most common cyanotic heart disease, what we call as a tetralogy of Fallot, basically came from Stenson, not from Fallot. But it took around 200 years for Fallot to describe the clinical and autopsy findings of a regular tetralogy, which we call as tetralogy of Fallot, thanks to a great Canadian pathologist, Maud Abbott, who coined the term Fallot's tetralogy. And then Hunter, one of the two Hunter brothers, who described the clinical findings of a presentation of a cyanotic spell without probably knowing that this was due to a congenital cyanotic heart disease. And then we come to the modern history in 1944, 1945. The first ever surgery on a cyanotic congenital heart disease took place in New Hopkins in US just towards the end of the Second World War. And that tribute again to the three masters, Helen Taussig, Blalock, and Vivian Thomas, who was a technician perfusionist. So it's now called, the shunt is now called Blalock, Taussig, and Thomas shunt. And Walton Lilly, who basically structured the corrective surgery, intracardiac repair of tetralogy of Fallot, which is probably the most common cyanotic heart disease at any age group except probably for a newborn period. Now, the prelude: whenever you have a cyanotic congenital heart disease or a hypoxemic congenital heart disease, there must be a right to left shunt. There has to be RBCs traveling from the right side to the left side. The majority of them will be inside the heart. Very few can be outside the heart, which we will discuss later. Now, this generally cyanotic heart disease is basically divided into two groups. One is a reduced pulmonary blood flow situation for our convenience, and increased pulmonary blood flow to the other group. But both group, that is reduced or increased or normal, should have a right to left shunt. Then only you will have a clinical cyanosis. Now, there are five major groups. Cyanotic heart disease with reduced flow can be due to pulmonary stenosis, or it can be due to pulmonary vascular occlusive disease. Now, with pulmonary stenosis, naturally you need a right to left shunt, and that right to left shunt, majority are due to a VSD. Very rarely, some of them can have no VSD, so the shunt will be across the atrial septal defects. Then the second important group is with increased pulmonary blood flow, which can again conveniently be classified into a parallel circulation like a TGA and an admixture like a single atrium, which we will discuss a little later. So I wish to propose, I propose to what you call as discuss this cyanotic heart disease clinical scenario in 7 acts. The first act is a older boy, non-congenital heart disease from infancy. He was possibly due to a block of a valve, was not blue at birth, now has become blue and becomes symptomatic. JVP is elevated with a single S2. There is some cardiomegaly also with a parasternal heave and a pansystolic murmur of tricuspid regurgitation. So basically, this child started as having a cyanotic heart disease. They do not do a shunt, but because of a block of a valve, then has become cyanotic. So it must be a pulmonary stenosis with which has developed a reversal of shunt at the atrial level, that is at the atrial septal defect, which is the one group of congenital cyanotic heart disease with reduced pulmonary blood flow without ventricular septal defect. Sometimes you can also have an Epstein anomaly with pulmonary stenosis, which can also present with this particular kind of finding. And the usual finding in a severe PS and neglected PS, which has gone into a blue baby, is basically will have a prominent JVP, cardiomegaly, significant left parasternal heave, and as I told you, not the obstructive murmur, but because of a tricuspid regurgitation. And you can see the X-ray where you have a significant cardiomegaly, right atrial enlargement, post-stenotic dilatation, and an RV kind of effects. And the ECG will show a right axis deviation, and a severe RVH, as evidenced by a QR pattern in V1, severe RVH. Now, the second act is probably the most common and the most popular act. That is a 3-month-old baby who is blue, not blue at birth, became cyanosed at crying. Now is resting blue color, no cardiomegaly, a single second sound, a mid-systolic murmur at the mid-sternal border with a saturation of 80%. So you know, even from at an MBBS level, we know this has to be a tetralogy of Fallot, which is relatively easy to diagnose because there will be no heart failure, no cardiomegaly, single S2, and an ejection murmur. Again, like tetralogy, there are 4 factors, 4 clinical findings of a tetralogy clinically. And occasionally, they can have a high volume pulse or a continuous murmur or sometimes a ejection click, which we will discuss. So this is the second group where you have a cyanotic congenital heart disease with reduced pulmonary blood flow with PS, but with a VSD. And the prototype is a tetralogy of Fallot, VSD with pulmonary stenosis, as you can see here, with a severe RV outflow obstruction. So as again we go back to the clinical features, normal JVP, no cardiomegaly, no heart failure, a relatively quiet precordium, a single S2, and an ejection or a mid-systolic murmur of varying grades. Then, as again for postgraduates, 2 terms I think you have to be familiar. One is the pentology of Fallot. Basically, it is Fallot with an additional atrial septal defect, which can be present in around 15%. And there is another misnomer, it's called trilogy of Fallot. So basically, ASD with PS, which I discussed as the first group of cyanotic congenital heart disease. But we must be familiar with these particular terms. Then we must also be familiar with syndromes which are associated with tetralogy, rubella, Down syndrome. The most common cyanotic heart disease in them are tetralogy of Fallot, then maternal PKU, and very, very importantly, DiGeorge syndrome, because up to 15% of tetralogy can have an associated DiGeorge syndrome on testing. Then there are some additional factors, added factors in tetralogy. For example, if you have a tetralogy with a high volume pulse, we must think of a tetralogy with a PDA, with a collateral, or a pulmonary atresia with the MAPCA, or trungus with pulmonary stenosis, which can produce a high volume pulse. Tetralogy can be man-made high volume pulse in a regular BTT shunt, that is called as a modified BT shunt. And in an adult, sometimes AR also can develop later, which can produce a high volume pulse. JVP, we discussed that JVP is normal in tetralogy, but rarely JVP can be prominent when VSD becomes restrictive. So adults develop a right heart failure or a systemic hypertension. Then continuous murmur, as I told you, basically PDA, not from the bronchopulmonary collateral, but from the BT shunt. And MAPCA occurs only in a tetralogy with pulmonary atresia. Now, we must look at conditions where you have a large VSD with pulmonary stenosis, which we call as a TOF physiology for our convenience. There are many conditions having this TOF physiology. Number 1 would be a double outlet right ventricle VSD PS, a single ventricle PS, DTGA VSD PS, LTGA, AVSD, everything with a pulmonary stenosis. And you have noticed that I have deliberately kept tricuspid atresia separate in a different color. The reason I will tell you a little later. And in a regular tetralogy, you find that there is no cardiomegaly on X-ray, RV contour, a small PA and branches because of the and causing concavity of the PA bay, and pulmonary oligemia, and sometimes a right aortic arch. This is a classical appearance of a boot-shaped heart in a tetralogy of Fallot. You also can have a right arch in 20 to 25% of tetralogy of Fallot. And as a postgraduate, you should know that there are other conditions like tetralogy, pulmonary atresia, and truncus arteriosus, which can have higher incidence of a right-sided aortic arch on X-ray. Whereas generally, X-rays are more or less similar, but electrocardiography can be variable in various types of tetralogy physiology, and it will differ in the TOF-like situations, and it is going to be very, very useful. So, between an X-ray and an ECG, in a TOF physiology, more useful would be an electrocardiography. The standard electrocardiography in a tetralogy would be, as you can see here, right axis deviation, right ventricular hypertrophy, and an early transition. Now there is another term called TOF variants, and three important variants which are described at the subspecialty level is a pulmonary atresia with VSD, absent pulmonary valve syndrome, and an atrioventricular septal defect with pulmonary stenosis. This is a picture of an absent pulmonary valve syndrome which can produce a to and fro murmur and sometimes can produce stridor in a regular tetralogy of Fallot. Now we come to another area which is very important for anybody. Four major complications of tetralogy: cyanotic spell, cerebral thrombosis, infective endocarditis, and cerebral abscess. And then you can also have a paradoxical embolism, bleeding tendencies at various locations, including the lung, hyperuricemia, and sometimes symptomatic polycythemia in a very severe tetralogy of Fallot. And again, one or two slides on spell mechanism, because again, this has been asked in the examination: spell at rest or spell on exertion. Spell at rest in a small baby could be due to an infundibular spasm with an abrupt reduction of pulmonary blood flow and hypoxemia, whereas spontaneous SVT is also supposed to produce a reduction in stroke volume by loss of AV synchrony, which can precipitate a spell. Whereas the regular spell on exertion like crying or feeding occurs because of the fall, abrupt fall in the systemic vascular resistance with increased right to left shunt and hypoxemia, and of course a cascade of events. And the management is basically oxygen inhalation, knee chest position, bicarb, morphine, beta blocker, and vasopressors. Then we come to the very important question asked in the examination, that is, when does tetralogy develop a heart failure, which is very unusual. So usually in pediatrics, it becomes develops heart failure when there is a VSD becomes small because of the tricuspid valve prolapse, which is very rare. It can also occur in infective endocarditis, and a medical condition like an iron deficiency status also can produce heart failure. Then other causes of heart failure would be exuberant MAPCA in pulmonary atresia, aortic regurgitation, systemic hypertension, and right heart failure in an adult tetralogy of Fallot. Suppose you do a central shunt for a tetralogy, that also can produce usually heart failure. And this, of course, is the most common cyanotic heart disease in adult also. So there are some differences in adult tetralogy of Fallot from a pediatric tetralogy, which sometimes are important. For example, there can be mild cardiomegaly, can be mild heart failure, then AR can be, clinical AR can be present, and bronchopulmonary collaterals are more in adults as expected. Now we come to the TOF-like situations or a TOF-like physiology, which we will run through quickly. And this is clinically, you can try to distinguish. X-ray is useful, but ECG is extremely useful in this situation. Now, X-ray is useful in differentiating the various kinds of tough physiology. For example, DTGA VSTPS can have a RV contour with a right atrial enlargement. LTGA can have a prominent aorta to the left side, L post aorta. Tricuspid atresia can have a right atrial enlargement. Truncus can have an abnormal pulmonary vascularity. And the tetralogy of pulmonary atresia can have a mottling appearance of the lung because of an extensive MAPCA. So first one is a DORV VSTPS, which is clinically indistinguishable from a tetralogy, but right arch is less likely. Extreme right axis may indicate a DORV. Prolonged PR interval also is possible. And early transition is less common, which is a very soft difference. This was actually an ECG of a DORV VSTPS. Basically, it shows RVH without early transition, which is classically found in pathology of fallow. Now, the second condition is a DTGA VSTPS. As expected, they will have a very early onset deep cyanosis, probably some cardiomegaly, but not usual. But the most important point is that good murmur with deep cyanosis. Generally, tetralogy of fallow, it becomes severe or severely blue. The murmur comes down in intensity, whereas in a DTGA VSTPS, you have a very interesting combination of a good murmur with deep central cyanosis. ECG will show simple RVH. X-ray will show the typical egg on side appearance with a reduced pulmonary vascularity. This is DTGA VSD with pulmonary stenosis. Now, RVH is the standard form. Then, this is another one, AV septal, single ventricle with pulmonary stenosis will have a prominent murmur. Apical MR murmur sometimes can be found. And a good murmur, again, a combination of a good murmur with a deep cyanosis. And the ECG is very important. There will be no Q in V5, V6. Why? Because it is a single ventricle. There is no interventricular septum. And you find an ECG where you can see from V1 to V6, there is a small R and a deep S, very characteristic feature, which I will show you on the left-hand side of the slide. Then AVSD with PF. Whenever you encounter an AVSD with PF, you should think of a Down syndrome. We should look for an apical MR murmur and a prominent JVP. And ECG is going to be very, very important because ECG will show a left axis deviation. Left axis deviation with some degree of atrioventricular block. And another very rare but interesting condition is an LTGA. And LTGA VSDPS can have sometimes bradycardia. So any top physiology with a brady should think of a LTGA because they can have complete heart block and JVP can be prominent. And the second left space will be palpable because aorta is occupying the second left space with a loud single S2, which is actually 8. And you can also have an MR-like murmur at the apex. And we must also remember in radiology that this is probably more common with dextrocardia with situs solitus or levocardia with situs inversus. As you can see, this is dextrocardia with situs solitus, and this is levocardia with situs inverse. Both will have the LTGA VSDPS situation. And as I told you, can have complete heart block, which may require a permanent pacemaker. And ECG again will show left axis deviation and varying degrees of AV block. And also, very importantly, some of them can develop have a SVT because of the WPW syndrome. And the very characteristic ECG, as you can see from V1, in V1, there is a Q wave in V1, which should not be there, and there is no Q in V6. So there's an inversion of the ventricle causing a Q in V1. And you can see the magnified QR in V1 and no Q in V6 in the classical LTGA ventricular septal defects. And this is again a pulmonary atresia with fallow. Fallow with pulmonary atresia will have an early cyanosis, high pulse volume because of the MAPCA or a PDA, and there will be no RV out murmur. There is no pulmonary stenosis murmur, but they will have a continuous murmur. And sometimes it's a severe fallow. and you can have a right side aortic arch in around 30%. Now, tricuspid atresia. See, actually, tricuspid atresia clinically behaves like a very severe early fallow. But interesting thing is that there is no epigastric impulse and there can be prominent A wave in JVP if you look very carefully. And ECG makes the diagnosis. This is a right atrial enlargement in a tricuspid atresia. But what is more important is a electrocardiography. As you can see here, there is a very tall P wave, almost like a Himalayan P wave. There is a left axis deviation, and then we have a poor RV force and a very good LV force. So four findings of a tricuspid atresia are right atrial enlargement, left axis deviation, poor RV force, and a good LV force. So that brings us to another important question or a very important area. That is, when you suspect a tetralogy of Fallot and you have a left axis deviation in the ECG, what will you think of? You should think of a tricuspid atresia, atrioventricular septal defect with single ventricle with PS and LTGA VSD, pulmonary stenosis. So, and clinically, we can make some distinction between tetralogy and tricuspid atresia. One is physiologically tricuspid atresia is not a TOF-like physiology. It is a admixture physiology. The onset is very early. Murmur is good. You have good murmur with deep cyanosis in tricuspid atresia. There will be no epigastric impulse and there can be LV impulse, which is not present in a usual tetralogy of Fallot. Then we have a truncus, which is very rare, which can present with PS sometimes with a high volume pulse and an early diastolic murmur. And you have a right aortic arch. In almost 50% of truncus arteriosus, you can have a right side aortic arch. Now, quickly, before going to the third, fourth, and fifth group of cyanotic heart disease, we will just look at the very important practical point, viscosity versus hematocrit in cyanotic heart disease. At a particular point of time, between 50 to 60% hematocrit, the viscosity rapidly increases. So you have to maintain, before surgery, maintain PCV somewhere between around 55 to make sure that they don't go for complications of hyperviscosity. And some of the postgraduates can look up OP-GAI to know what is the amount of blood to be removed and replaced by venesection in a severely polycythemic child. And these are all. This is a very important slide, I suppose, because majority of a cyanotic congenital heart disease with a single S2. So they can ask you what are the causes of cyanotic heart disease with a well-split S2, which is classically found in TAPVC and single atrium, Epstein anomaly, and sometimes in AVSD with severe pulmonary arterial hypertension. Another is now, can you recognize these two people, the leading lady and probably the greatest ever thespian of Indian cinema? And why this picture is important in this discussion, we will discuss little later. This is a child, as an adult, 19-year-old girl with a history of a hole in the heart in infancy, improved later, but now has come with a progressive dyspnea. And very interestingly, the upper limb saturation is 95% and the lower limb saturation is 82% with dyspnea. This was the ABG of this particular patient, right radial 95, femoral is 82 with a PO2 of 52. So you make, and basically, initially it used to be a left to right shunt, a hole in the heart, now has developed a cyanosis. The prototype is a Eisenmenger syndrome. The simple Eisenmenger syndrome can occur in ASD, VSD, AVSD, ductus, and AP window. And this happens to be a PDA with Eisenmenger syndrome. And this is basically an Eisenmenger syndrome with PAH with the reversed central shunt. And the presentation is a history of heart failure in infancy, late onset cyanosis with severe pulmonary hypertension. And that can be classified into simple, that is the usual one, the complex, and the post-surgical or a post-palliative Eisenmenger syndrome. And there are two terms, again, we should be familiar. Eisenmenger complex is VSD with Eisenmenger, whereas Eisenmenger syndrome, which was coined by Paul Wood in 1958, includes all the defects, including VSD, PDA, ASD, or whatever. That is Eisenmenger syndrome. And it's very important to remember that it may present by second or third decade, but it gets established by 2 to 3 years. So it is our purpose, avoid child developing, prevent the child developing an Eisenmenger syndrome. Very, very important. And radiology will show basically no cardiomegaly with a very huge pulmonary artery. This is a typical X-ray of a VSD Eisenmenger with a very huge pulmonary artery and peripheral pruning. This is an X-ray of a ASD Eisenmenger with cardiomegaly, very important point, with a hugely dilated pulmonary artery. And this is a PDA Eisenmenger with minimal cardiomegaly with a calcified ductus because of a hugely dilated calcified ductus in adult practice. And ECG basically will show severe right ventricular hypertrophy, as you can see here, a monophasic R wave in V1 with the right axis deviation. So now you know why Madhubala was brought in, because she had a VSD Eisenmenger and died at the age of 36 years. Now we come to another group, a 4-day-old baby. So we have covered 3 groups. And the fourth group is a 4-day-old newborn, blue from second day, acute high volume pulse, hardly any murmur. So whenever you have a cyanosis in day 1, day 2, day 3, first week of life, without much murmur, you should think of a transposition physiology, a parallel circulation with deep cyanosis, mild heart failure, variable pulse, and hardly any murmur, unless, of course, they have pulmonary stenosis or a restrictive ventricular septal defect. So basically, TGA is all about a symptomatic neonate with deep cyanosis and cardiomegaly with a single S2 and inconspicuous murmur. That is very important. It's a typical X-ray of an egg on side appearance showing cardiomegaly, RV contour, right atrial enlargement, and a narrow pedicle with a normal pulmonary vascularity, and it's an egg on side appearance. But you must remember that egg on side appearance usually presents to you only after 3 weeks of being blue. So you must make a diagnosis of TGA much before they develop a egg on side appearance. In the ECG will show a monotonously dull ECG showing right ventricular hypertrophy. Now, there is a 22-day-old baby, has heart failure with a white split second sound with a murmur, and tinge of cyanosis. Saturation was 90%. So whenever we have a wide split second sound with a tinge of cyanosis, you should always suspect a total anomalous pulmonary venous connection, unobstructed. The classical X-ray of a figure of 8 appearance, which is also called a snowman appearance in a unobstructed supracardiac TAPVC with RVH with the strain pattern. So this brings us to a fourth group called admixture lesion. This mixing of both-sided blood can occur at the atrial level, single atrium and TAPVC, ventricular level, single ventricle and DORV, and the arterial, that is truncus arterial. 5 major admixture lesions. And the basic tenet is that they will have mild cyanosis with significant congestive heart failure. So basically, quickly what you can say is that if you have an infant, ASD-like clinical finding with cyanosis, think about DAPVC. VSD like with tinge of cyanosis, think of single ventricle. PDA with a high volume pulse with cyanosis, think of a truncus arteriosus. And this is a single ventricle with a large, they will present with a, just like a large VSD with a mild arterial saturation. X-ray will be no different from a large ventricular septal defect. But what is important is the ECG, where there will be no Q in V5, V6, and there will be small Q and a deep R in precordial leads. This is another 20-day-old baby, again with severe heart failure, mild cyanosis, but femorals are bounding. So you will think that it is basically due to PDA, but there are multiple murmurs, especially the early diastolic murmur at the base. You should always think, if you have a PDA-like picture with a high volume pulse, continuous murmur, or an early diastolic murmur at the base, think of a truncus arteriosus. ECG will be simply showing a biventricular hypertrophy. Now we come to another interesting situation. So basically, we have tried to cover five major groups, reduce pulmonary blood flow into three subgroups, increase into two subgroups, that is a parallel circulation and admixture lesion. We come to another interesting condition, a 7-day-old baby with heart failure, hypoperfusion, and severe cyanosis. Very bad situation with a well split second sound, loud P2, and both systolic and diastolic mom. So very sick baby with all the problems like heart failure, cyanosis, and hypoperfusion. We should think of an Epstein anomaly, which is very sick neonatal presentation. But you must remember that Epstein anomaly can have variable age of presentation from newborn to adulthood, variable cyanosis without any cyanosis to severe cyanosis, split first sound, split second sound, lot of additional sounds like an S3, S4, multiple murmurs. You should think of an Epstein anomaly. And JVP can be normal, it can be elevated in this thing. And a very important finding in an Epstein anomaly would be the third space pulsation, which is very, because basically in clinical cardiology, there are only two conditions. We'll have a third space pulsation, Epstein anomaly, and a right ventricular endomyocardial fibrosis, which is practically unknown nowadays. Very, very important. And the second sound will be split. So this is one of those conditions where you have a split second sound in a cyanotic congenital heart disease. And ECG is very characteristic, which shows a very tall P wave, prolonged PR interval, RBP pattern with a splintered QRS, very classical. So a bizarre looking ECG in a cyanotic child with a very Himalayan P wave, very tall P wave exceeding that of a height of a QRS complex, which is called a Himalayan P wave. And 15% of Epstein anomaly can have a WPW syndrome, which can lead to a supraventricular tachycardia. X-ray is very characteristic, a box-like heart in an X-ray with a huge right atrial enlargement, pulmonary oligemia, and a narrow base of the heart. This is Epstein anomaly. Now, towards another very interesting situation, very rare, of course. An 8-year-old girl has central cyanosis, clubbing, no cardiomegaly, normal heart sounds, no murmur. X-ray is apparently normal, ECG is normal. Echo was reported as normal, but the interesting thing is ABG showed a PO2 of 56, saturation of 75%. So whenever a child has a cyanotic congenital heart disease without murmur, and without major abnormality in X-ray and ECG, but genuine hypoxemia and desaturation, you should think of a pulmonary AV fistula. This is the one condition where I told you in the beginning that there can be a right to left shunt outside the heart. So this is basically an example of a pulmonary AV fistula. So basically the difference will be between pulmonary AV fistula and methemoglobinemia, because methemoglobinemia also can present like this. Well, the point is PO2 in methemoglobinemia will be normal. So ABG will be enough to direct you to the possibility of a pulmonary AV fistula. So whenever a child has a pulmonary AV fistula, you will have central cyanosis, clinically normal CVS, normal ECG, near normal X-ray, and a normal echocardiography, because intracardiac anatomy is absolutely normal. You must make a diagnosis by a contrast echocardiography. So finally, as an epilogue, Manish, we have 5 minutes for MCQs.
Okay, sir, we have 5 minutes.
Yeah. Quickly, I'll just go through the multiple choice questions, quickly covering whatever we have learned so far. One is differential cyanosis can occur in all these congenital heart disease except PDA Eisenmenger, DTGA VSDPS, PPHN, and interrupted aortic arch syndrome. So the right answer, except, that is, DTGA VSDPS will not have differential cyanosis. Now, high volume pulse in congenital heart disease is found in Rungus, pulmonary atresia with a PDA, TOF with BT shunt. So TAPVC will not have a high volume pulse. A bradyarrhythmia in congenital cyanotic heart disease, we have discussed, it will occur in LTGA VSDPS because of a complete heart block. This finding is quite unusual in tetralogy. You will have a normal JVP, no single S2 with systolic murmur, but no cardiomegaly in regular tetralogy of fallow. This cyanotic heart disease is not included in top physiology. It's very important. Clinically, a tricuspid atresia behaves like a severe fallow, but it is actually physiologically, it is not a top physiology. It is an admixture physiology. Then top-like clinical picture with left axis, we have four conditions. One was LTGA, another was a single ventricle tricuspid atresia. So here the answer is LTGA, VSDPS. Now, TOF sometimes can have an asymmetric pulse after a surgery that is classically found in a classical VT shunt where the subclavian artery will be sacrificed. So you will have that pulse will be relatively weak in that particular condition. Then TOF-like condition, which congenital heart disease will you get? Deep cyanosis and good murmur, classically in in a DTGA VSTPS, also in tricuspid atresia, and sometimes in a single ventricle with pulmonary stenosis. Then this is very important, as I showed you the X-ray, Eisenmenger syndrome will have a cardiomegaly. Usually they will not have cardiomegaly, but they will have cardiomegaly in ASD Eisenmenger. And well-split second sound is classically found in Epstein anomaly. It is also found in TAPVC and single atrium. These are the three important cyanotic congenital heart disease, which will have a well-split second sound. And a well-split second sound, this is Epstein. Then Himalayan P wave, we have just shown that Himalayan P wave in Epstein anomaly. And the last MCQ, cyanotic heart disease with clinically normal CVS, normal ECG, and apparently normal X-ray can be found in pulmonary AV fistula. The differential diagnosis will be a metabolic condition called methemoglobinemia. So thank you very much for your kindness in accepting me in the post-lecture session. And thank you very much. And I'll be glad to interact if the time permits. Thank you very much.
Thank you, sir. Dr. Vikas and Dr. Ruli. Yeah.
Thank you very much, sir,
So,
for such an enlightening talk. And I hope we have learned a lot. If I talk about the practitioner's point of view, especially those who are dealing with neonates, it is very, very important to identify the cyanotic heart disease in a newborn, because when to refer and to whom to refer is very, very important. Because you have to differentiate whether it's pulmonary cause versus the cardiac cause. Then you have to decide whether you want to keep the child at a center where immediate surgery is if needed is available or not. So these questions are very, very important in initial 48 to 72 hours. Sir will be agreeing with me.
yes,
So
absolutely.
this quick decision, pulmonary versus cardiac, then is it the center where if the child needs surgery is to be done? So I request sir to kindly enlighten the practitioners and the neonatologist about these very important action window, which is important.
Okay.
Over to you, sir.
I think that's very, very important. Actually, I had put those slides of a newborn approach to newborn cyanosis, few slides, but time factor, I omitted it, unfortunately. But the basic point is that clinically also we should start suspecting whether it is respiratory or cardiac. For example, if you have a respiratory rate or a grunting and LNAs working, it's more likely to be respiratory. And we know the problem with the second sound is important, murmur is important, perfusion issue, all those things will point to a cyanotic heart disease. But as I agree fully with you that it will be sometimes very difficult to pick up between cardiac and respiratory. So olden days we used to have this hyperoxia test where we used to give oxygen, but now I think pulse oximetry has to some extent has improved our picking up of a critical congenital heart disease, because majority of a critical congenital heart disease was especially on the right side are having hypoxemia. So if you take a saturation, pulse oximetry saturation in the upper limb and lower limb, at least three groups of cyanotic heart disease you will pick up. One is that parallel circulation or a top physiology or all those conditions or a critical coarctation with a tinge of desaturation in the lower limb, which can be picked up. I think pulse oximetry has become very useful. And I am not very sure that nowadays in our center, basically the hyperoxia test, which is basically giving oxygen for 10 minutes and seeing the increase in PO2, is not regularly done, because we have probably obviated the use of that hyperoxia test by using the pulse oximetry, and possibly because increased access to echocardiography. I think that is one point I want. But I agree with you that in a peripheral hospital or a semi-central hospital, it will be sometimes difficult without an echo to make sure that this is you are dealing with a. Even in Trivandrum, where we have right now, the hospital I am working has one of the highest level tertiary center in neonatology. There again, we basically many of the time we need an echocardiography to differentiate between what we consider as PPHN or a critical congenital heart disease. I think, it's an incomplete answer, but I
Thank
think
you,
it's
sir.
an obvious answer to that question. But I think the point is that for a postgraduate, especially a clinician or a postgraduate, even clinical differences between a respiratory cause and a cardiac cause, including simple things like tachypnea, grunting, LNSA working, respiratory rate, heart rate, perfusion, murmur, the degree of P2, loudness, etc. I think can be useful to some extent. And then, of course, we take an X-ray and ECG. Probably ECG may be probably more useful than an X-ray, because X-ray interpretation of a newborn with a critical CHD is many times, you know, not very, very foolproof.
Thank you very much, sir. So I think I have to request Dr. Munish Madam to start a point of care eco, course next time. That will
Exactly,
be the
focus.
need of the hour.
Yeah.
And we have got Dr. Roli has joined us. Now evening over here. Dr. Roli, good evening for your expert comment on such a wonderful session.
Yeah,
Namaskar.
good evening, everybody. It was indeed a very interesting and very enriching experience listening to Sir, and very nicely explained, Sir, about the differentiation between the increased and decreased pulmonary blood flow. Usually, we get the reference from the neonatology and the pediatrics. Uh, Mostly, neonatology people are very much concerned about the cyanosis, and many of them who don't have, as Dr. Vikas rightly said, many of the centers who do not have echocardiography support or backup, they are actually baffled whether it's a cardiac issue or a
Respiratory.
respiratory issue, especially when the baby is very sick within the first few hours or maybe 1 or 2 days. And it's very difficult to differentiate between PPHN and some cyanotic congenital heart disease which may present. And definitely, sir, as you said, some basic investigations, ECG, echo, ECG and X-ray, and clinical examination will definitely help in making at least a differential diagnosis, if not coming exactly to the diagnosis itself. And thank you, sir. Thank you for such a nice lecture.
I think it's very important. Manish, you must make. I mean, next time we should have a session on critical congenital heart disease in the neonate. I think that will be, because
Exactly, exactly.
for example, both Vikas and you, Rolly, both were stressing on the neonatal, because it's a major issue. Because when a child, I agree with you fully, because when a child of a 6-year-old child or a 6-month-old baby comes with a suspected